Hello everyone, I'm Dr. Rohan Khandelwal, a surgery faculty, and in this video I'll be talking about the high yield images and tables which I would like you to revise before the INICET exam. In this I've included the extremely high yield topics, so I would really want you to watch this video, and if you have a doubt in any of these topics, I would want you to read it before the INICET exam. So the first topic is skin grafting, which is usually asked in the exam. You know the basic differences between split thickness skin grafting and full thickness skin grafting. In split thickness skin grafting, epidermis plus some part of dermis is taken. So epidermis plus some part of dermis is taken in split thickness skin grafting, whereas in full thickness skin grafting, the entire epidermis and dermis is taken. What I really want you to remember is regarding primary and secondary contracture, which has been asked in various exams. Primary contracture is the contracture which occurs when you raise the graft off the donor bed, right? That is primary contracture, and that is directly proportional to the amount of dermis which is present. So that is why primary contracture is more with full thickness skin grafts, whereas secondary contracture, which is the contracture which takes place when you put the graft on the recipient bed and then the graft shrinks, that is secondary contracture. That is inversely proportional to the amount of dermis, and that would be seen more with a split thickness skin graft. This is a Humvey's knife, which has been asked many times in the exam. This is what a split thickness skin graft looks like. Once you raise it, you will see these punctate bleeding points. We can carry out meshing of the graft by cutting this graft, by making slits in the graft. We can increase the surface area, and it prevents seroma formation, which is accumulation beneath the graft. Reinnervation in a graft starts 4 to 5 weeks and is completed by 12 to 24 months. And you should remember that pain is the first sensation which returns, and light touch and temperature return later. The most common cause of graft failure is a hematoma beneath the graft. Others are infection, movement or shearing force, and poor recipient bed. Another very important topic for the exam is frostbite and trench foot. Now you should know the basic difference between frostbite and trench foot. Frostbite is when ice crystals are formed and they cause tissue membrane damage and microvascular damage, and rewarming might lead to reperfusion injury. There are 4 stages of frostbite. 1 is just hyperemia, 2 is large vesicles, there's skin loss as well, 3 is when there are hemorrhagic vesicles and full thickness skin loss, and 4 is when muscle or bone is involved. Trench foot is when there is prolonged exposure but the tissue is wet as well. In frostbite the tissue was not wet, here the tissue is wet, and that can also lead to microvascular damage. The management is what is important for both of them. In both we carry out gradual rewarming, and very important, which you should remember, we should not rub the tissue, because rubbing the tissue can lead to extreme pain. We should be aware of reperfusion injury. Hyperkalemia and acidosis can occur in these patients, and if gangrene occurs, we wait for the demarcation line to form before we do amputation. Bed sores are extremely important, and invariably if they ask you the grade of bed sore, it would usually be a grade 4 bed sore. If they show you an image, here you can see the muscle is exposed. So you should know the grades of bed sores. Grade 1 is just non-blanchable erythema, 2 is partial thickness involving epidermis and dermis, 3 is subcutaneous tissue, and 4 is muscle layer. So this is the same as the grading of burns as well. The most common site of bed sores is ischium, followed by the greater trochanter. You should know the basic composition of crystalloid solutions as well. This is very important. This is ringer lactate. This composition is ringer lactate. And anytime you have a solution which has lactate and calcium in it, there's only one answer, that can be ringer lactate. So you should know the composition of Hartmann solution and normal saline. These have been frequently asked in the exam. This is a vac dressing, which is a negative pressure or vacuum assisted closure, in which minus 125 millimeters of mercury pressure is used to hasten wound healing. These are the uses of vac dressing which have been asked in various exams. They are used for chronic non-healing wounds, venous ulcers without slough, burns without eschars, bed sores after debridement, and diabetic foot ulcers without osteomyelitis. SIRS and QSOFA are frequently asked. Questions from shock are frequently asked in the INICET exam. You should know the SIRS parameters, and SIRS is temperature more than 36 or less than 36 or more than 38, I'm sorry, respiratory rate more than 20, heart rate more than 90, and white blood cells either less than 4,000 or more than 12,000 or more than 10% band forms which are present. You should also know the QSOFA criteria. The QSOFA criteria respiratory rate is more than 22, whereas in SIRS it is more than 20. So please don't get confused, as usually this is what is the answer in the question. Class 2 shock is 15 to 30%, and this table is extremely important for the exam. Invariably there's one question from this table which is asked, and just the summary of this table, you should know that tachycardia is the earliest manifestation of hypovolemic shock, and class 2 will be tachycardia but systolic BP would be normal. Class 3 would be tachycardia and BP also starts to fall, and class 4 is when the BP is unrecordable. And the approximate blood volume loss, you can remember it as the scoring of a tennis game. Class 1 is less than 15, class 2 is 15 to 30, class 3 is 30 to 40, and class 4 is more than 40. Very common question asked in the INICET exam is Trali and Taco. So this was a patient who was transfused FFP, and 3 to 4 hours after transfusion he becomes breathless. Chest X-ray shows batwing appearance. This is Trali, and this occurs due to anti-HLA antibodies. So Trali is transfusion-related acute lung injury. Transfusion-related acute lung injury. There are antibodies against HLA antigens. It leads to non-cardiogenic pulmonary edema, usually within 6 hours. And the implicated donors are usually multiparous women, and you will get this ARDS-like picture. I've already told you that QSOFA and SIRS are extremely important. You need to remember the parameters. Anti-DVT stockings, anti-DVT pneumatic stockings have also been frequently asked. They are a mechanical method of DVT prevention. This is another question which has been frequently asked. If the finger is severed during an accident, how do we transport that finger? We wrap it in saline gauze within a plastic bag and place it in an ice container, right? So wrap it in saline gauze, put it in a plastic bag, and then the plastic bag is put in an ice container. Very, very important for the exam are the various IV lines. You should know the color coding, and you should know the flow rates of the common cannulas. Like orange is 240 milliliters per minute, gray is 16 gauge, it is 180. Green was asked last time, it is 18 gauge, 90 to 96 milliliters per minute. Pink is 20 gauge, which is 60 milliliters per minute. So this you should remember. Drains have been asked in the exam. This is a Romovac suction drain, which is a closed suction drain. This is a miniature version known as Minivac. These can be used after thyroid and breast surgeries. Jackson-Pratt has also been asked. This is used for abdominal surgeries, and the way you differentiate a Romovac from a Jackson-Pratt is that Jackson-Pratt has a bulb instead of a container, and it has a flat tubing in the end as opposed to the cylindrical tubing of Romovac and Minivac. This is a corrugated rubber drain, which is an open drain. This is an abdominal drainage system, whereas this is an underwater seal. This has also been asked where the lower end of the tube is submerged underwater. This is used for chest tubes. When we connect an intercostal tube, we always use an underwater seal bag. Again, a very, very important table where you should know about clean, contaminated, and dirty wounds. You should know the examples, and you should know the risk of surgical site infection with antibiotic prophylaxis and without antibiotic prophylaxis. We know that the best time for antibiotic prophylaxis is 30 to 60 minutes prior to surgery, and for a clean wound the risk is 1 to 2%. For clean contaminated with prophylaxis it is 3, without it is 6 to 9. For a contaminated wound it is 6% with prophylaxis, without prophylaxis it is 13 to 20%. For a dirty wound, it is 7 with prophylaxis and 40 without. Hand washing, hand hygiene, and prevention of wound infection is another important topic. The areas which are frequently missed, even if you do a proper hand wash, are the thumb, interdigital clefts, and the tips of the fingers. The 5 moments of hand hygiene as described by WHO: we need to do either a hand wash or hand sanitization before touching the patient, after touching the patient's surroundings, before a procedure, or if they are exposed to bodily fluid. Very important, you need to remember that if the hands are visibly soiled or if you visit the toilet or the bathroom, then you need to wash the hands with soap and water. This has also been asked in the exam. ERAS is enhanced recovery after surgery. This is an important concept, and you should know that we discourage the use of nasogastric tubes. So now, up till 2 hours prior to surgery, clear liquids can be given, carbohydrate rich liquids can be given. Solids have to be stopped 6 hours. We avoid mechanical preparation, give adequate analgesia, avoid drains and nasogastric tube. Early ambulation and early initiation of nutrition is done in these patients. These form the ERAS criteria which help in early discharge from the hospital. This is a Varies needle which is used for pneumoperitoneum. It has been asked many times, and the maximum flow rate which we can achieve is 2.5 liters per minute. This also you should remember using a Varies needle. There are various angles which are there in laparoscopy. 3 angles are there: azimuth, manipulation, and elevation angle. The ideal manipulation angle is 60 degrees. The manipulation angle, as you can see, is the angle between 2 working ports. Ideally it is 60 degrees. Azimuth angle is the angle between the working port and the endoscope or the camera. And elevation angle is the angle between the instrument and the horizontal plane. Triage and trauma are extremely important. Triage, you have red, yellow, green, and black. Red is high priority, yellow is medium priority, green is ambulatory, and black are the dead patients. Red category, you require emergency or immediate care. Yellow, you require urgent care. You have your fractures in yellow category. Green is delayed. Blue is a new category which is expectant treatment. These are the moribund patients who are about to die or moribund patients. Black are the dead bodies. Tension pneumothorax is a constant feature in the exam. Tension pneumothorax and cardiac tamponade. You should know how to diagnose it on an X-ray. You should know the various scenarios that you will get a hyper-resonant note on percussion. There will be tachycardia and hypotension. And the emergency management is needle thoracocentesis, which in adults now is done in the 5th intercostal space in the mid-axillary line. For children, it is still the 2nd intercostal space in the mid-clavicular line. E-fast can be used for tension pneumothorax. It is loss of seashore sign. You can have barcode and stratosphere M sign as well. We tape it on 3 sides whenever we are dealing with tension pneumothorax. Chest tubes are inserted in tension pneumothorax, that is the definitive management, and it is inserted in the triangle of safety, the boundaries of which you should know for the exam. It is bounded by the axilla. Inferiorly, you have the 5th intercostal space. Anteriorly, you have the interior axillary fold, and posteriorly, you have the mid-axillary fold. These are the boundaries of the triangle of safety which you should know for the exam. Head injury scenarios are also frequently asked. Diffuse axonal injury, I've listed the key words which you need to know. In diffuse axonal injury, you will get a shearing force between grey and white matter. There will be no improvement in GCS. NCCT will be normal, and investigation of choice would be MRI. EDH or extradural hemorrhage, you will see it in young patients. High velocity impact, lucid interval can be seen, and NCCT would reveal a biconvex hemorrhage. Subdural hemorrhage, usually in elderly patients after trivial trauma, and there will be gradual decline in sensorium over a few weeks, and you will see concavo-convex hemorrhage. A 37-year-old nulliparous patient on OCPs, mother and sister had ovarian and breast cancer. What would be the next step? We would do genetic counseling and BRCA testing. So any strong family history of breast and ovarian cancer, you will do BRCA testing. Triple negative breast cancer, less than 60 years, male breast cancer, bilateral breast cancer, all these would be indications to carry out genetic counseling and BRCA testing. We should stop tamoxifen at least 3 months before if the patient is planning to conceive, and we usually stop the tamoxifen and then only we ask the patient to conceive. Frozen section is important, and frozen section we send the tissue without saline or formalin, right? Without saline or formalin, that is how we send the tissue. Frozen section, we don't send the tissue in saline or formalin, please remember that. And frozen sections can be used for to know if the lymph node is positive or not, sentinel lymph node, to know if the margins are positive or not. All these we can know by frozen section. We send the tissue without saline or formalin. IHC for HER2/neu, if it is 0 and 1 plus, it is negative. 2 plus is equivocal, and in 2 plus we carry out FISH. FISH is fluorescent in situ hybridization. This has also been asked many times. Please remember, FISH is only carried out if HER2/neu is 2 plus. Very important definition, you should also know the images of locally advanced breast cancer. Locally advanced breast cancer is T3 N1 M0, any T4 with M0, or any N2 or N3 with M0. These are the definitions of locally advanced breast cancer which you should remember. A patient on anastrozole, one investigation which we will do is DEXA or bone density scan, because anastrozole and letrozole are aromatase inhibitors and they can lead to reduced bone density. Bilateral mastalgia or fibroadenosis, placebo effect is seen with evening primrose oil. This is written in Bailey and you should remember this for your exam. A very frequently asked question is regarding the histopathological slide of papillary thyroid cancer, where you get orphan aniide nuclei or intranuclear inclusions, and we can see samoma bodies as well in these patients. In medullary thyroid cancer, you will get amyloid-rich stroma. Masoka classification is used for thymomas. Mediastinal tumors you should know about, which are most common in anterior. It is thymoma. Thymoma is most common overall as well. Bariatric surgery, the indications you should know, and indications for bariatric surgery are more than 35 with comorbidities, more than 40 without comorbidities as well. These are the indications which you need to remember. One new indication which is coming up is between a BMI of 30 to 34.9 with diabetes mellitus or metabolic syndrome. There is limited evidence, but this is also coming up as one of the indications. Rigler's triad and Mirizi syndrome are two scenarios which you should definitely know for the exam. Rigler's triad is seen in gallstone ileus, and Rigler's triad is pneumobilia, features of small intestinal obstruction, and a radiopaque shadow in the right iliac fossa. So gallstone ileus is secondary to cholecystoduodenal fistula, right? This you should know. Most common site is the terminal ileum. Rigler's triad I've already told you. And the emergency management is treatment of the obstruction. Cholecystectomy is done in the next sitting. Mirizi syndrome is when the gallbladder becomes adherent with the CBD. The stone pushes against the CBD. So in Mirizi syndrome, patient will have jaundice, raised ALP, and ultimately a fistula forms between the CBD and the gallbladder. Intra-abdominal abscesses, you should know, most common site overall is the pelvis. In a supine patient, it is hepatorenal pouch, and in an ambulatory patient, it is also pelvis. CCT is the investigation of choice, and we drain it using a pigtail catheter. Which would be the most commonly encountered ectopic tissue in Meckel's diverticulum? We know it is gastric and pancreatic, and that is what leads to bleeding. The ectopic gastric mucosa leads to bleeding. It is seen along the antimesenteric border. It's a true diverticulum, and the rule of 2 is applicable here. If it's an asymptomatic or broad-based diverticulum is incidentally detected, we leave it. If Meckel's diverticulitis can mimic acute appendicitis, and if there is a perforation, we carry out resection and anastomosis. You should know that bleeding is the most common presentation in children. It is due to the ectopic gastric mucosa, and a technetium 99 per technate scan is the investigation of choice. Obstruction secondary to intussusception is the most common presentation in adults. Achalasia is a constant feature in the exam which you should know about. You get the bird's beak appearance on barium swallow. It's an important barium, and POEM is one of the modalities to treat achalasia. This stands for per oral endoscopic myotomy. So questions like these have also been asked. Whenever you're suspecting achalasia, if you have a patient with weight loss as well, you should also carry out an upper GI endoscopy to rule out malignancy, right? So whenever you're dealing with achalasia, always rule out malignancy as well. So those would be the two differentials. Gas under diaphragm, frequently asked scenarios where a patient is taking NSAIDs or has come with peritonitis, rebound tenderness, guarding, rigidity, and you're shown an X-ray, you will see gas under diaphragm. This is a sign of hollow viscous perforation. In such patients, we have to carry out resuscitation and take up the patient for an emergency laparotomy. The incisions for appendicectomy are important, and you should know which muscle layers do we go through during these incisions. You have the McBurney's incision, in which gridiron is the muscle splitting incision, whereas Rutherford Morris is the muscle cutting incision, in which we cut the external oblique aponeurosis, the internal oblique muscle, the transversus muscle, and then we will reach the preperitoneal fat and the peritoneum. Lanz is skin crease incision, it is cosmetically better, and a midline incision is used for a perforated appendix. Rectal prolapse surgeries images have also been frequently asked in the exam. This is Thiersch wiring where a purse string suture is taken. Delorme's repair is when we hitch up the mucosa all throughout circumferentially, and rectopexy is when we use a mesh. This is an abdominal procedure. The previous two which I mentioned, Thiersch and Delorme's, were perineal procedures. Abdominal procedures have less recurrence, whereas perineal procedures have a high recurrence rate. Mirizi's syndrome I've already explained to you. This is what Mirizi's looks like. Whipple's is again a constant question which is being asked in the exam. You should know the image to diagnose Whipple's surgery. This is pancreaticoduodenectomy, which is done for periampullary cancers or head of pancreas cancers, and 3 anastomoses are carried out. We carry out a pancreaticojejunostomy, a gastrojejunostomy, and a hepaticojejunostomy. You should know the most common anastomosis which leaks is the pancreaticojejunostomy. Also, a pylorus preserving Whipple's can be done, in which we save the pylorus, and if we save the pylorus, dumping can be prevented. So all of the following statements are true about inflammatory bowel disease. Inflammatory bowel disease, Crohn's can have skip lesions, childhood IBD can be genetic, Crohn's is fully curable is wrong, and Crohn's is mucosal and ulcerative colitis is transmural, that is also wrong. You should know the differences between Crohn's and ulcerative colitis. Inflammatory bowel disease, since the last 2 years, they have been asking it in the exam as well. Crohn's, you should know that smoking increases the risk, and not to CART15 gene is the one which is the genetic basis of Crohn's. Ulcerative colitis, you have continuous spread, whereas Crohn's you can have skip lesions. Crohn's is transmural, whereas ulcerative colitis usually involves the mucosa and the submucosa. Ulcerative colitis, definitive surgery can be carried out, whereas in Crohn's, definitive procedures are not possible because of the skip lesions which are there. Crohn's disease can mimic acute appendicitis. Ulcerative colitis usually comes as bloody diarrhea, and the number of diarrhea episodes during the day can determine the frequency and the severity as well. Another very important topic is idiopathic hypertrophic pyloric stenosis, and usually you will have the firstborn male child, and the typical metabolic abnormality which you get is hypokalemic, hypochloremic metabolic alkalosis with paradoxical aciduria. So you will see a visible peristalsis from left to right. There will be a palpable olive-shaped swelling. The diagnosis is using an ultrasound, which is diagnostic. The thickness is more than 4 millimeters. Length is more than 16 millimeters. The fluid of choice is N by 2 normal saline with dextrose plus KCl. KCl is added when the kidney function test is normal. Like I've said, this is usually seen in the firstborn male child, and reduced levels of nitric oxide synthase have been implicated. Trisomy 18, Apert and Cornelia de Lange syndrome are also features. To treat gastroesophageal reflux disease, we carry out a fundoplication, and this maneuver where we mobilize the fundus around the esophagus, this is known as shoe shine maneuver. This you should know about. Which of the following procedures cannot be done after mini gastric bypass? ERCP cannot be done. So this you should know that we cannot carry out ERCP because we will carry out a gastrojejunostomy. And for ERCP, we want that the endoscope should go in the duodenum. Endoscope should go in the duodenum. So we cannot approach the duodenum if we've done a gastrojejunostomy. That is why ERCPs are not possible after you've done a bariatric Roux-en-Y or a mini gastric bypass. The ideal time to operate a child with inguinal hernia is as soon as it is noticed. Foley's catheters, you should know that outer circumference, French stands for outer circumference, that is 2 pi r, French stands for outer circumference. Ureterocele, you should know that you will get cobra head or adder head appearance. This is a very common question which is asked in the exam. You should also know about posterior urethral valves where you will get the keyhole defect. You can get keyhole defects here. And you should also know about ectopic ureter. In an ectopic ureter, you should know about Weigert-Mayer's rule. Weigert-Mayer's rule is that the ureter which is draining the upper part of the kidney will open more distally and medially as compared to the ureter which is draining the middle and the lower part, that opens normally. In males it opens in the urethra, and in females it opens in the vagina. It opens in the vagina, which is why a female will have normal voiding pattern and continuous dribbling as well, and that tells us that there is an ectopic ureter. If there is a non-palpable testis which is not palpated in the inguinal region, we will carry out diagnostic laparoscopy, that is the investigation of choice, and the best time to operate these patients is after 6 months. So these were the questions which I wanted you to know for the exam, and these are the topics which you should definitely revise before the exam. They are important, and just make a note of them. If you have any doubts regarding them, go back to your notes and quickly revise these topics, because these are the ones which are frequently asked. In the last few days leading up to the INICET exam, please focus on your 20th notebook if you've made it, and focus on the previous year questions. All the very best for your exam. Thank you.